I am Diana Artene, PhD in oncology nutrition, and let's discover how to eat properly after cancer. The concept of geriatric nutrition seems as peculiar for people who do not need geriatric nutrition as does oncology nutrition look like for those without cancer. What is the big deal in planning your meals? Why should we eat anything if we ate in a certain way all our lives? Why bother with geriatric nutrition anyway? In the real world, and not in utopia, in which the majority of these discussions and personal opinions usually take place, the nutrition of the elderly is still not implemented in most hospitals, nursing homes, and not even at home. For instance, the World Health Organization recommends a protein intake of 0.8 grams per kilogram of body weight to healthy adults and to 1.2 to a healthy elderly, which means the elderly should eat 50% more proteins than the adults. In the case of elderly patients diagnosed with cancer, the recommended protein intake should go up to 1.5 until 2 grams, that is, double the protein intake recommended for a healthy adult. Still, the surveys and studies presented at the last ESPEN Congress revealed that the protein intake for healthy old people varies between 0.6 and maybe 0.8, and this already insufficient intake even for an adult further decreases throughout the oncology treatment if we fail to inform and support the patient to double up the protein intake. A dietitian's job is to diagnose and treat the food-related problems and malnutrition in order to improve the health conditions and the quality of the patient's life, but most patients have no access to high-quality nutrition. High-quality nutrition meaning nutrition based on scientific evidence and practiced by dietitians specialized in clinical and oncology nutrition and not by the so-called self-proclaimed nutritionists. The presentations at the Congress were done by specialists from civilized, developed and rich countries such as Austria and UK. And according to their studies, in UK, 57% of cancer patients did not receive any professional nutritional support, while in Austria the percentage rose to 72%, malnutrition affecting more than half of the cancer patients. And although malnutrition influences the treatment, the response to the treatment side effect, and the survival rates, even in such highly developed countries, old patients are often advised about their diet just based on costs and calories. Still, the studies done by researchers like Calea in 2015 and Stratton in 2018 showed that although oncology nutrition practiced by certified dietitian comes with a cost, for the British cancer patients who were supervised by an oncology dietitian starting at diagnosis, they saved annually an amount of 73.6 million euro. Therefore, despite the fact that oncology nutrition seems expensive, using this support therapy from diagnosis leads to an overall lowered price of the oncology treatment and to an increased quality of life after the cancer diagnosis. And moreover, there are international studies certified by the European and American Societies for Medical Oncology, which show that the patient's access to oncology dietitian from as early as diagnosis is associated with an increased overall survival. Nevertheless, most of the persons responsible for the foods provided to oncology patients only bother to equal the recommended calories with the lowest price possible. Thus, many simply choose to advise their patients to just eat anything and eventually to take some supplements. When thinking about nutrition, many people only think supplements, or at best, maybe also some enteral or parenteral foods. But nutrition is mainly about normal foods, not about supplements and not about enteral and parenteral nutrition products, which are usually recommended only when either the patient cannot tolerate oral foods or when she or he cannot cover the nutrition needs through the eaten food. Many people that get to decide what a patient eats in the hospital do not take into consideration the patient's the digestion and absorption capacity, which are potentially influenced by the type of surgical procedure, by the surgical complications, by the potential side effects of the chemo or radiotherapy. Some even fail to consider whether the patient can chew or swallow or digest the food. And at that conference, the experts presenting there even displayed a photo of a cachectic patient with esophagus cancer during radiotherapy who was lying on a bed. And next to this poor man's bed, there was a table with a very, very beautiful apple on it. And it was beautiful, red and untouched, similar to the one in the Snow White fairy tale. And this apple was impossible to ingest by a patient with a painful dysphagia brought about by the ton of graze units administered to his esophagus. We need to understand that the most important aspect of oncology nutrition in geriatric patients is increased protein intake. But our elderly patients either eat sweets, fruits, and pasta because these contain neither salt nor fat. Either they fast for religious reasons, as if God had a database including the days in which they decided to misbehave and eat meat, eggs, or dairies. Some say the chances of going to heaven are inversely proportional with the steak one eats. But since the main goal of oncology nutrition is to delay the trip to heaven as much as possible, most oncology dietitians recommend against any type of fasting during cancer treatment. We want to keep the patients here on the ground and not underneath it, and that is the reason why after a cancer diagnosis, properly cooked steak is more than allowed. Nonetheless, because even in hospitals from Austria and UK, more than half of the patients never get to hear any professional oncology nutrition, we can extrapolate that even in such civilized countries, many old patients are usually exposed to 3 unprofessional nutritional advice. And the first one is from the priests. That general message is that the elderly should fast from time to time to wash away their sins. But fasting during oncology treatment diminishes treatment efficiency through muscle loss and enhances inadequate nutrition intake. The metabolic consequences of a too low intake of meat, fish, milk, or fermented milk products, cheeses, and eggs are more obvious in the case of those suffering from cancer than in the situation of those without cancer, because those during treatment, they have bone loss and muscle mass loss associated with the treatment administration. And although it may seem that a low supply of meat, fish, or eggs can be compensated by an increased supply of beans or peas or lentils or chickpeas and so on, the enhanced content of fibers from these vegetal foods reduces the absorption of the already fewer proteins contained by these plants. And the problem is not that the vegetable proteins may or may not cover the necessary protein intake of old people. Theoretically, mathematically, or over a cup of coffee, we can discuss if 1 + 1 = 2, irrespective of the protein origin being plant or animal. But if one given by the vegetable protein actually brings less amino acids, which are harder to digest and assimilate than the 2 obtained by 1 + 1 from vegetable protein sources, has a lower biological value than the 2 obtained by 1 + 1 from animal protein sources. And this is the advice from the priest. The second advice comes usually from the cardiologist, and the general message is that the elderly should avoid the consumption of salt and fat. And in reality, the slogan "avoid the consumption of salt and fat" practically means avoid the consumption of proteins of animal origin, since the foods many people perceive as containing salt or fat are eggs, milk, cheese, dairy, meat, and fish. And the foods considered as being devoid of salt and fat, or lower in salt or fat, are pasta, sweets, and fruits, especially fresh fruit juice made from all sorts of fruits, which will only stuff the body with high amounts of fructose and worsen dyslipidemia, steatosis, and hyperuricemia. These metabolic syndrome disorders may be addressed with specific medication, but without a proper protein intake, in time they will only worsen, causing increased liver toxicity of the treatment by steatosis and dyslipidemia, aggravation of diabetes due to the subsequent insulin resistance, and sarcopenic obesity as a result of increased muscle catabolism amplified by the too low protein intake. And this is the advice from the cardiologist. And the third advice that our elderly patients usually receive are from all people taught by Dr. Google, that tells our patients that milk is only for calves. And for some, even speaking about milk in oncology settings sounds like a blasphemy, a sheer blasphemy. Still, according to the current scientific data, milk proteins actually have anti-carcinogenic effects. The intake of milk, dairy products, and cheese contributes to preventing oral mucositis, esophagitis, and duodenitis induced by the radiation therapy, and which this is very, very important when radiotherapy is administered alongside chemotherapy. The intake of milk, fermented dairy products, and cheese also contributes to maintaining muscle mass, counteracting hyperglycemia, lowering the risk of cardiac toxicity of this treatment, maintaining a normal level of liver transaminases, and in some cases even of transaminitis, reducing cholesterol, and is also associated with increase in overall treatment efficiency. And regarding the digestion and absorption capacity of milk and dairy products and cheeses are the easiest to digest foods, even in the case of old people. It is true that 70% of the old have lowered lactase secretion in comparison with the younger adults, but this difference in numbers is purely mathematical and has no clinical manifestation in most of our patients, and is rarely associated with improper lactose digestion and very seldom with lactose intolerance. Despite opinions, milk products remain some of the most digestible foods on the planet, quite adequate and wholeheartedly recommended for the elderly patients. Popular but general, non-individualized nutritional advice provided randomly based on supposition and all sorts of personal beliefs has a strong impact on the elderly patients, because they are incredibly compliant. With very few exceptions, I am highly impressed by the results of my elderly cancer patients, and after 7 years of working with cancer patients day by day, my conclusion is that as long as the old person diagnosed with cancer clearly understands what he or she needs to do, the things are as good as done. Like in the Nike commercial, they just do it. So, my dear elderly patients, please know that the most significant nutritional recommendation you need to sustain your oncology treatment is to eat twice as many proteins as a healthy adult.